Thanks everyone for attending this. And I promise I'm not going to bore. As anybody who might know me knows I can talk. I promise only to spend 10 minutes going over what I think are the key points of the paper I wrote. I'm not going to talk too much about what we've done. I would much rather that we have an open discussion, because I think, this is a big problem and we all need to work together to try and figure out what the answers are, or potential answers are. The idea is to provoke a discussion which will help us understand the terrain of mental health in the modern world, and particularly the role of technology in helping to improve what is now our biggest health problem. A map, however bad that map might be, will inform us as to where we might be, illuminate possible places we want to go, and give us some idea of how long and what preparations we might need to take to get to those places. However, I would first like to place what I'm about to say in context. This quote is by E.O. Wilson, and E.O. Wilson, for anybody who doesn't know, is regarded perhaps as the foremost scientist alive in the world at the moment. And his field of study is ants. But it's ants and their social behavior, which we start to see the connection with mental health. And it informs everything we do at co-ops, because it succinctly illustrates where we are, hints at the potential problems we have to face and overcome because of that trifecta of Paleolithic emotions, medieval institutions, and godlike technology. We think it's particularly relevant for mental health because we believe those 3 points of view must always be kept in mind to fully grasp the problem. One perspective on its own is not going to help you. So in reverse order, if we look at the godlike technology, its advantages and disadvantages when we look at applying it to mental health, its biggest advantages are its relentless consistency. An algorithm never gets tired or distracted. It can be easily replicated, and so can scale quickly, and is generally cheaper than using people to do the same. But that's not always the case. Recently, if you're not aware, there's an algorithm called GPT-3, which is a text processing algorithm. But that algorithm cost over $30 million to train. And there's a newer version now that is about 10 times the size, and the estimates there are in excess of $100 million to train it. That's definitely not cheaper than people. However, there are also disadvantages with technology. And they include, I suppose, top of the list, issues around privacy and confidentiality. Do we know and understand where data goes, how it's processed, and the associated risks, not the least from hacking and cyber criminals trying to intercept that data? Complexity is another disadvantage. The complex web of interdependent systems we now rely on in modern business and healthcare is probably beyond the understanding of most people, and that increases risk. It's Donald Rumsfeld's famous unknown unknowns. Scope is another disadvantage. Sometimes we spend too much effort trying to maximize returns on investment, and we risk losing everything. And there are really good examples in healthcare, and in particular in the NHS. I'm thinking of an initiative about 10 or 15 years ago, integrated patient records. Implementation and training is another big disadvantage, because too little time and effort is spent on implementation and training. And it's usually way too late in the process before we get around to trying to win users' hearts and minds. And recent initiatives with the NHSX in terms of PPI and the emphasis on PPI in grants is improving this, but we've still got a long way to go. And the last disadvantage is the human cost of change. Change is hard for humans. We don't like it. We'd rather the status quo. And that, is perhaps the single biggest point of failure for most technology. When we look at mental health, and the institution of mental health, we're looking at the biggest health problem we now face, probably bigger even than COVID. In the UK, its annual cost is almost the same now as the entire NHS. You'd think for such a large problem, we'd have got to grips with it. But so far, we have no models to describe what a mental health problem actually is. Perhaps this is a because of an impact, because on an impact basis, a like-for-like basis with cancer, cancer gets 32 times the research spending that mental health does. This is translated historically into mental health being the Cinderella service and not in health services. And it may account for some of the siege mentality that you occasionally find within mental health institutions. It also counts for the enormous pressure brought to bear on an already overstretched staff. So perhaps one of the most intrinsically motivated workforces who aren't doing it for the pay, but to actually help people. And yet they end up suffering twice the burnout rate, twice the sick leave rate, and twice the vacancy rates of any other medical profession, let alone other professions. And it might account for the shortage of people entering the profession. Now, we need to recognize that therapists are human beings too, not supermen and superwomen. When therapy started over 100 years ago, it wasn't an unreasonable thing to assume that because the therapist was usually better educated, they were in some sense better, but quotes around that. But when we find that patients forget between 40 and 80% of what they're being told in clinical situation, that's also happening to the therapist. The solution to that problem is that we get therapists to take notes. But we introduce another, more insidious problem, multitasking. Behavioral psychologists will tell you that humans can't multitask. They end up being bad at both tasks. Again, we find evidence that some clinicians recognize the harm that it does to the therapeutic alliance when there's an absence of notes in the patient record. Having said that, the evidence is still that talking therapies are still the most effective in dealing with the wide range of poor mental health we see presenting. Perhaps it's because language and face-to-face communication is so fundamental to our social existence. The most significant determinant to positive outcomes is still the patient turning up and wanting to improve. However, there's another aspect to the Paleolithic emotions. Recent work by Daniel Kahneman has shown that under conditions of uncertainty, human judgment is only a little better than a random walk. Those Paleolithic emotions that have successfully got our species to its current zenith get in the way, and before we are even aware, they affect our judgment in ways we're not even aware of. It happens in what Kahneman calls his system one. So before we're even thinking, we've already, our subconscious has delivered an answer. You could also call this clinical intuition. In the diagram there that Kahneman used to illustrate what the problem is, there are 4 possibilities. We're accurate in our judgment. We've got noisy judgment. We've got biased judgment. Or we've got noisy and biased judgment. Only one of those 4 possibilities is good. But there's a 1 in 4 chance, only a 1 in 4 chance of being in that box. And it is only after making the judgment that we can evaluate it. But we don't have a mechanism to do that in therapy. Supervision usually happens too late and too removed in time and place, and also involves only half the people originally in the room and is essentially self-reporting. So now to the question, what should we be trying to do? Dawes and Baker are individually critical of clinical psychology's use of scientific information and adherence, though that is changing for the better with the advance of evidence-based therapies. But in the absence of large-scale data, progress is going to be very, very slow, and we need to solve that data problem. The second problem to be confronted is clinical intuition. In the absence of data and models, it will try and fill that void. To challenge it, we need experiential learning, which means a clear understanding of what constitutes an incorrect response or error in judgment, and, importantly, is immediate, unambiguous, and consistent in terms of feedback when such errors are made. Profession under pressure and with a stressed out workforce will tend to revert to core beliefs and resist change, but this problem is too big for change not to happen. Change is inevitable, but there is still time to shape that response before it is imposed. That's the question I leave to you. Thank you very much.